He showed me his exercise journal, weeks of entries, consistent, disciplined, committed, and I had to sit there and tell him that several of those exercises, ones I might have even suggested years ago, were likely making things harder for his body, not easier. He showed me his exercise journal, weeks of entries, neat handwriting, every session logged, the exercise, the sets, how he felt after, consistent, disciplined, committed in a way that most people never are. And I had to sit there and tell him that several of those exercises, ones I might have even suggested years ago, were likely making things harder for his body, not easier. He didn't argue. He just looked at the journal for a moment and said, "So all of this was for nothing?" And that question has stayed with me, because the answer isn't quite that simple. The effort wasn't wasted. The direction just needed adjusting, but I understood why it felt that way. He had done everything right by the old playbook. He just hadn't been given the updated one. That conversation is a big part of why I'm making this video. That's when I realized something. Some of the exercises I've recommended for years, I no longer feel comfortable recommending in 2026. Not because they're dangerous, not because exercise is bad, but because for a certain group of patients, and probably a lot of people watching this, these exercises aren't the answer they've been made out to be. Exercise 1. Traditional toe, touch hamstring, stretch. The logic makes sense on the surface. Tight hamstrings contribute to back pain, so stretch the hamstrings. But the standing toe touch doesn't just load the hamstrings. It drives significant flexion through the lumbar spine. And for anyone with disc sensitivity, even mild degenerative change, or a history of disc injury, that repeated end-range forward bending can aggravate rather than relieve. After 40, discs become less hydrated and more vulnerable to compressive and flexion loads, particularly first thing in the morning. What I use instead? Hip hinge patterning, teaching the body to bend from the hips while the spine stays neutral. Same goal, better mechanics. Exercise 2. Sit-ups for core strength. Sit-ups have been the default core exercise for decades. The problem is that core strength isn't really about flexion. It's about resisting unwanted movement. Sit-ups generate repeated shear and compressive force through the lumbar discs. Research, particularly from spine biomechanist Stuart McGill, identified this as a concern for cumulative disc loading over time. For someone already dealing with back pain, high-rep sit-ups can reinforce the very patterns causing the problem. What I use instead? Anti-extension stability work. Planks, dead bugs, and Pallof presses train the core to stabilize, which is its actual job. Exercise 3. Aggressive lumbar twisting rotation exercises are often prescribed for spinal mobility. And in the thoracic spine, rotation is exactly what we want. The issue is when that rotation happens primarily in the lumbar spine. The lumbar vertebrae are designed for forward and backward movement, not rotation. Aggressive lumbar twisting can irritate facet joints and stress the annular fibers of the discs. What I use instead? Controlled thoracic rotation drills, keeping the lumbar spine stable while encouraging movement where the body is actually designed to rotate. Exercise 4. Deep forward folding holds. This type of exercise has real benefits. This isn't about this practice as a whole, but sustained, end-range forward folding, held for 30, 60, or 90 seconds, places a prolonged stretch load on the posterior disc structures. Combined with the age-related changes in disc hydration I mentioned earlier, this can be problematic for a subset of patients. The position itself isn't the issue. The duration and degree at end range are. What I use instead? Neutral spine mobility work, moving through range without camping at the extreme end. Exercise 5. Hyperextensions, Supermans. This one is still widely recommended for strengthening the back. And while it does create some posterior chain activation, the position itself loads the facet joints and posterior elements of the spine under compression. For anyone with facet arthropathy, spinal stenosis, or spondylolysis, this can be directly provocative. Yet it's often prescribed without any screening. What I use instead? Glute-driven hip extension. Bridges, hip thrusts, and single-leg variations train posterior chain strength with far less spinal compression. If you've been doing one of these consistently and your pain hasn't changed, that's not failure. That's feedback. Your body has been telling you something. The goal now is to listen more precisely. Stay with me, because the last 3 on this list are the most misunderstood and the most commonly still recommended online. Exercise 6. Heavy deadlifts for fixing. Back pain deadlifts done well are a genuinely excellent exercise. That's not in question. The problem is the prescription of heavy deadlifts for people who haven't yet built the movement foundation to support that load. When capacity doesn't match demand, the lumbar spine compensates, and that's when injuries happen. I've seen patients come in having read that deadlifts cured back pain, and they've pushed weight before their tissues were ready. What I use instead? Progressive graded loading, starting with body weight hip hinges, building toward loaded variations over weeks, not days. Exercise 7. Child's pose for every case. Child's pose is deeply relaxing and genuinely helpful for many people, but not all spines respond to flexion-based decompression. A significant portion of back pain patients have what's called a flexion bias issue, meaning flexion is actually part of the provocative pattern. For these patients, child's pose can temporarily worsen symptoms. What I use instead? Assessment first. Understanding whether someone is flexion intolerant or extension intolerant changes the entire exercise approach. There's no single decompression posture that works universally. Exercise 8. Foam rolling the lower back. Directly, this one surprises people. Foam rolling works well on muscular tissue. The hips, thoracic spine, and glutes respond beautifully to it. But the lower back is different. The lumbar spine sits in front of the erector muscles. You're not actually reaching the structures you think you are. More importantly, rolling directly on the lumbar spine can create a levering effect on the vertebral segments, which isn't what most people need more of. What I use instead? Foam roll the hips, the glutes, and the thoracic spine. The relief you feel in your lower back often comes from releasing the structures around it. Exercise 9. Random YouTube 7-minute fixes. I say this knowing I'm on YouTube right now, so let me be precise about what I mean. Generic online routines aren't designed for your spine, your history, or your movement patterns. Pain is a symptom. It is not a diagnosis. Two people with identical symptoms can have completely opposite drivers and need completely opposite interventions. Following a random routine without that context is like taking someone else's prescription medication because you have similar symptoms. What I use instead? Movement pattern screening. Identifying whether the issue is a mobility deficit, a stability deficit, or a neuromuscular control problem. That changes everything. Exercise 10. Stretching the area that hurts. This is perhaps the most common and most understandable mistake. Pain is here, so I'll stretch here, but pain is frequently referred. The area producing symptoms is often not the area generating them. Hip stiffness creates lumbar load. Thoracic restriction changes how force travels through the whole spine. Tight hip flexors alter pelvic tilt. Stretching the symptomatic area can feel temporarily good and do very little to change what's actually driving the pain. What I use instead? Treat the driver, not the symptom. That usually means looking upstream and downstream from wherever it hurts. Pattern recognition. Looking at this list as a whole, there's a pattern worth naming. Most of the outdated advice follows the same logic. Stretch more, load more, push through. But most people with chronic or recurring pain don't have a stretching deficit. They have a stability deficit. Their joints are moving, sometimes too much, without enough neuromuscular control to protect the surrounding structures. Movement quality matters more than movement quantity, and doing more of the wrong thing doesn't build tolerance. It builds compensation. This isn't about doing less. It's about doing smarter. Sectile assurance close. I want to leave you with this. I didn't stop recommending these exercises because they don't work for anyone. I stopped recommending them automatically, because the word automatically is where things go wrong in pain management. Pain needs context. Progress needs strategy. And when you're working with a body that's been hurting for months or years, guessing, even educated guessing, wastes time that you don't need to waste. You are not fragile. Your body is not broken. It has simply been given instructions that don't quite match what it needs right now. That's fixable with the right information. If your pain keeps coming back despite staying active and putting in the work, the next step isn't pushing harder. It's getting clarity on what's actually driving it. If you're ready for that, the information is here when you need it. Take that next step when it feels right.